Dr. David Rosensweet, welcome officially to the Fit Mother Project podcast, my friend.
Dr. Anthony Balduzzi. I'm pronouncing that correctly?
You are. Very good.
I'm most honored. Thank you.
Well, this is going to be a really powerful and fun conversation, and something I think I could even say is a long time coming to have an expert of your caliber come on and talk about this world of hormones and bioidentical hormones. And I know I read some stuff in the intro, but I just want to edify you some more. Like, you are one of the pioneers of this field, which is so cool, because I'm sure your career, you've seen just this explosion of something that you saw early in your career was like, wow, I think this is going to be really big. Hormones are foundational to our anti-aging and vitality. And now look at the landscape now. It's everywhere. And I think it's only expanding now when women are getting a better grasp on how to live well through menopause and the different kinds of changes. So I want to go deep today on all things hormones. So please, though, give us a little background on why you got interested in this when you were in medical school, and like what prompted you to become, someone so interested in female hormones.
I love medical school. It was like a temple to me. It was a very sacred experience. And yet, as I was wrapping up my senior year, I wondered, are there any other tools out there to help people get well? And then when I went into practice, I could tell that the people were coming to me, they wanted to get results. They wanted to improve their health and heal. And so I went seeking tools. This is as early as 1970. And I wound up exploring the world of nutrition and toxicity and exercise and the elephant in most people's room, how we respond, functionally or not, to stress. And so I had a functional medicine practice long before it had a name. And
Cool.
30 years ago, one of my patients in her mid-40s, brilliant, she had retired in her mid-40s. Think about that. She came storming into my office one morning, extremely upset, and said, "Look, don't think you know me. I'm actually going crazy," which was a surprise to me because I knew her quite well. And serendipitously, so to speak, I had been speaking with a world expert on progesterone, Dr. John Lee, gave her some progesterone. 3 weeks later, I get a letter from her saying, "I can't believe this stuff. I'm totally myself again." That was very impressive. I've never really guided my career, or in many ways my life. It's unfolded, so to speak. And before I knew it, I had this menopause practice, and it really suited me well. It was time for me to specialize because I couldn't get my arms around the functional knowledge medicine world data knowledge base anymore. It was gotten too huge.
Yeah.
And so it was a perfect fit. I started zeroing in and specializing and treating women and now men in menopause and andropause. And it's extremely rewarding.
That is beautiful. And I love what you said, and it just resonates with me deeply. You said your life is kind of unfolded. And I'll not to push anything on you, but I think that's the hand of the divine moving through with your interests. And that's a powerful combination and means you're deeply on purpose.
Yeah.
Now I want to get a little technical for a moment and maybe define, at least for the ladies listening, some of the main hormonal levers that we do have, some of the main hormones that we do have, the ones that you pull. You mentioned progesterone. Other ones that women are certainly familiar with would be estrogen, maybe pregnenolone. Like, what are some of the, and even testosterone, right? I mean, very valid as well. So can you give us a little bit of a landscape of the biochemistry around this time of menopause? Like, what are some of these hormones? What are their functions? And like, what are you kind of looking at? And I know that's a big question and it's probably pretty individual, but insofar as you could kind of give us the real basics so someone can understand this, would be helpful.
Women, the ovaries produce 4 hormones, and they all really matter. And they're very powerful. They're some of the most powerful biochemicals in our body, and their output, women peak around the age 20, plus or minus a couple of years, and then gradually decline, then have a rather precipitous decline when estrogen gets too low and they stop having periods, but the decline carries on. Well, the consequence of this is enormous. These hormones are found in the brain and the bones and the muscles, everywhere you can think of. So 85% of women, by the time the estrogen gets that low for no period, they start experiencing life-disruptive symptoms.
Yeah.
Mood, can't sleep, no energy, vaginal dryness, vaginal atrophy, pain on intercourse, loss of muscles. You mentioned testosterone, loss of cognition. small, medium, large, severe in 85% of the women. I think the severity is very useful because it drives women to seek solutions. And the solutions are replenishing of the hormones, not to youthful levels for most women. There are exceptions, but to levels that really sustain the bones, the vagina, the muscles, so important, the brain, the arteries. And so it's the estrogen family, progesterone, testosterone. Testosterone is not a male hormone. It's a human hormone. Women need it as much. It's what keeps women out of assisted living facilities and nursing homes for the most part, so they don't lose their muscles. So, yeah, they're coming out of the ovary for men. We're coming out of the testicles. This is for women. I'll stick to it.
Yeah, that's beautiful. I mean, I think, and also it brings up the concept of what's natural. And I've actually listened to some of your talks in podcasts before, and you make this point that I think is really cool. There's this bias that we have that we all want the natural solution. It seems like it's the right way to go. But in a sense, like, these bodies have a natural trajectory of decay, right? Menopause and andropause are as natural as you can be. And I think people naturally experience frustration when they do the same diet and exercise stuff, but it stops working when they're 55 and their estrogen levels tanked, right? That is a natural experience for millions of people. So how do we rectify this idea of, maybe a natural bias with, we can do therapies that are not exactly natural. I mean, we can use natural hormones and natural delivery methods, but it's kind of getting us on an unnatural, but maybe even better course. Let's speak into a little bit of the philosophy of treating these hormones.
Well, natural in so many spheres of health and healing does matter. And there's been a body blow to natural, and why so many more women think natural times 20 when it comes to menopause. And that was this. Women have been treated and men have been treated with hormones for over 1,000 years, documented. We know this.
Yeah.
And by 2002, 40% of all American women, 18 million who were in menopause, were being treated with hormones. And then out comes this study that was falsely reported. It suggested there was increased risk with one of the arms of the study. And it exploded out of the media, and it was seen by healthcare providers and women all over the world. And it said that there was increased risk for breast cancer, heart attack, and stroke. And it terrified women. And overnight, 18 million went down to 1 or 2 million.
Wow.
Yeah. And to this very day, you hear echoes of this. Women want to emphasize, well, I'm going to go natural, because they're still living with the poison of that information, which was totally false. So if I could take a moment, because I love this question, that to really clarify what risk is scientifically, because we know a lot about it. And we're all at, is it all right that I
please,
do that?
Let's go. Yeah.
Yes. We're all at risk for thousands of diagnoses. We're all at risk for hundreds of cancers. As men, we're at an increased relative risk for prostate cancer. And there's new reasons for this. This was not always so. And women are at increased relative risk for developing breast cancer. There's new reasons for this. When I was in medical school, this was not so.
Sure.
Given that we're at risk for a lot of stuff, here's the science. Women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who are not treated with hormones. I go into this in my book, Happy Healthy Hormones, which your audience is welcome to download a PDF copy of, in chapter 3. And there's a biblical, elevated to the level of Bible reference work on this, called Estrogen Matters, by an oncologist specialized in breast cancer, if you really want to get into the details. But that's the science. Women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who are not treated.
That's good news for people here to hear. And does that mean still patients who come in and get treated through your clinic are getting family history work done, seeing if there's hormone-sensitive cancers? Does that factor in, or is it pretty much even with those potential familial risk factors, it's still pretty much better for most people?
Well, that's another excellent point. There's two in there. One is that proper treatment, and we really care about standard of care and developing this as a board-certified specialty, needs to be. We go through a rigorous medical process like everyone hoped they would receive when they go to solve a health problem. And you betcha, our approach to this is very detailed. And not more so than other explorations into health issues, but it doesn't leave anything out, in my opinion. The second part of that question is, I'm having a dropout for a moment. There was another important thing you brought up
Family
there.
history.
Oh, yes, receptor sites.
Yeah.
Well, long before we knew about the receptor sites, the estrogen receptor site beta became known in the late 90s. There was an oncologist, Avram Blooming, who decided his wife and his daughter had breast cancer. This is long before the Women's Health Initiative. That came out in 2002. He's an oncologist that specialized in breast cancer. He treated his wife and daughter with hormones, Premarin, Premarin, Prempro.
Yep.
And he ran a study. And this is before anything around receptor sites was known. And what he saw, this is where he first started developing the conclusion that women who had prior breast cancer and had that breast cancer properly treated were at less risk for recurrence. And that's an additional piece of science that I'd like to add that you brought up here.
Yeah.
That women who have had breast cancer and had that breast cancer properly treated, they happen to be at an increased relative risk for the recurrence of that breast cancer. However, if they're treated with hormones, they're at lessened risk for recurrence than if they go untreated. That much we know. That's the science.
Yeah.
Now, there's concern about estrogen receptor site beta. You have a hormone-sensitive cancer. Well, this is a very, very gray area, and it's a distinction that Dr. Blooming will not get behind. He said, in any given cancer, the tumor itself, there's cells that are so undifferentiated, they're so out of control, a pathologist can barely recognize them as breast cancer cells other than they were extracted from a breast cancer tumor.
Yeah.
They're so primitive. They're so undifferentiated. They're so out of control. But also in those tumors, there's a certain percentage of cells that didn't get that out of whack, that was still well differentiated. And any breast cancer cell has receptor sites.
Yeah.
He says it's not those cells within an excised tumor that have been the problem. It's those undifferentiated cells.
That's fascinating because we like to think of it's this kind of completely homogenous group of cells that are expressing the same receptors, and it's like you all have estrogen receptor positive cancer cells. But that's cool to realize that okay, we can detect that, but it's the different undifferentiated cells that are more problematic.
Oh yeah, and they're not responsive to anything.
Yeah.
Nor does Dr. Blooming believe, and I've had personal conversations with him. I flew out to LA to meet him when he came out with this phenomenal book called Estrogen Matters, in which the science of risk, and any woman who's had breast cancer and is concerned about being treated or not treated should read this book. There's 450 scientific references. This is not based on someone's, I think it's a good idea type thing.
Cool. All right. Well, I want to pivot a little bit because I think we've talked about some of the risks, but I actually would like to talk a little bit about the benefits even in the process that someone can go through to get bioidentical hormones. And let's make the distinction maybe with what does it mean to have a bioidentical hormone replacement versus non-bioidentical? And what does it actually look like in a process? So let's say someone comes into your clinic, they get worked up. They're a great candidate for this. You tailor some kind of hormone cocktail for them. How is it delivered? What does it actually look like in someone's life and what do they experience? I want to get into the process of it all.
Well, going back into the history again, the Chinese had bioidentical hormones 1,000 years ago. They collected the urine of young women and dried it out. And the powder left behind was given to the aristocrats who did much better than the rest of the population. And then it was a good idea that was replicated by the pharmaceutical industry in the 1940s. Instead of collecting human urine, though there was a venture into that, they decided to choose the urine of a large animal, a horse, a pregnant mare, and they catheterized these horses and collected the urine, dried them out, and developed the world's most popular and profitable drug of all time up to that time, Premarin, or combined with the progestin Prempro, because there's a lot of hormones in our urine and in horses' urine.
Yep.
And, as time went on in the early 1980s, simultaneously, a pioneer medical doctor, Jonathan Wright, who you mentioned, Suzanne Summers, he worked with her for years, and also a pharmacist outside of Dallas, Jim Hernser, had the idea, they had a realization that the pharmaceutical manufacturers were actually producing, though it wasn't very popular, bioidentical, same molecule. Instead of horse urine, which has 50% of the estrogens in that horse urine, have never been seen by the human female. The pharmaceutical industry had gone so far as to purify from plants molecularly identical, same molecule as the ovary puts out, estrogens, progesterone, testosterone, and DHEA. And Jim Hernser is a pharmacist. He was treating his wife. He put it in a skin gel, and it worked. And it was very dramatic. And Dr. Wright did the same thing in Washington. And so that was really the birth of using and prescribing molecularly identical. That's what bioidentical means. And they're prepared, primarily they're extracted these days from soy. Soy produces a precursor. Pharmaceutical manufacturers have exquisitely precise processes in which they know how to do biochemical conversions. They convert them to the same molecule that's coming out of the testicle or the ovary.
That's cool.
Yeah. And so this has been known since the 80s. And I picked up on it in the early 90s. And when I was faced with the choice of, Premarin on this hand or compounded bioidenticals on this hand, I went for the bioidenticals for a lot more reasons than that. There's a level of precision that can be done because women vary so much as to how much estrogen, for example, they need. Some women need this much to be healthy, regularly menstruating, be fertile, carry pregnancies to term. Other women need 3 times or more that much. They're still healthy, they're regularly menstruating, and everyone's in between. No problem clinically. And I described the process of dose determination in my book. But we need that level of variation. We also need a hormone called estriol to do best work. The young woman, she has more estriol coming out of her ovary than she has the sum of estradiol and estrone, the other two bioactive. And so we like to copy nature. And then in the 90s, we come to realize that a couple things based on studies in the 60s, healthy women have more estriol than they do the sum. Women who had breast cancer have less estriol than they had the sum of estrone and estradiol. That's when Dr. Wright originally proposed not using just estradiol. He relied on Dr. Lemon's work and decided to use Triest and then Biest. Biest has a lot of estriol in it, maybe up to 80% of it, because in a female menstrual cycle, every single month, she prepares for possible pregnancy. She also prepares her breast for possible lactation. That begins, and she gets breast glandular cell proliferation. And if she does not get pregnant, that breast glandular cell proliferation, that fullness of breast that they experience, deproliferates. That deproliferation is under the auspices of an estrogen receptor site beta that's primarily influenced by estriol. We want estriol. This is not commercially available. This is available through every one of the 7,500 compounding pharmacists in the United States. So there's a lot of technical issues that have led me towards, right out of the gate, actually, to prescribe with compounding pharmacists.
Hey, it's Dr. Ray. I want to quickly pause this episode to thank you so much for listening to this Fit Mother Project podcast. I am just blown away at how amazing this podcast has become, all the powerful stories, all the great expert interviews, and I am so grateful for you for tuning in and being here with everything we're creating here at the Fit Mother Project. And I just wanted to pause to acknowledge you and thank you again for listening. Please keep listening and tuning in to all the great stuff we're doing here at the FMP. Let's get back to today's episode. That was really good, and I want to make sure people understand this. And that's basically my quick recap here is there's several different types of estrogen, 3 in particular that are very important. They vary over the course of life. They have patterns that are indicative of healthier patterns versus unhealthier patterns. Young women have more estriol, lower estriol levels, and that's different than the main estrogen, estradiol, A2, that many people talk about. And that everyone needs to have their own unique preparation that's kind of like dialed in through proper medical application of these things. And when done in this way, this is probably why we see lower risk of women having, certain cancers when they're treated by bioidentical hormone replacement therapy and all this. Like, it's just generally protective and goes with the body's rhythms. So how do you deliver these things? Are they pellets? Are they creams? Are they pills in
Well,
some instances?
there's optimal ways to deliver hormones. There's many ways to deliver them. By mouth is not the optimal way for estrogen. A certain number of young women, for example, who were on the birth control pill, developed thrombophlebitis, a clot in their legs. Some of them went to their lungs. There's reasons why oral estrogen is not the optimal way to do it. It's rare, but it happens.
Yeah.
And so the optimal way to deliver estrogen is by skin, applying it to the skin in some kind of cream or gel. Or we've gone ahead and developed an organic oils base.
Cool.
Certified organic oils base. There's no solvents in this because the creams and gels are very strong solvents. They have to be to dissolve. Well, we don't ask for dissolving. We use suspensions. They work beautifully. And so I say, I want to give you my best shot. The best way to deliver it is through a certified organic oil base to the skin. Same with testosterone. That's the best.
That's really cool.
Yeah. Thank you. Progesterone can be, we always start a woman off with the same topical application of progesterone, but it also can be successfully and safely delivered orally.
Yes.
Testosterone cannot be safely delivered orally, although there are some preparations. Most of the preparations that have been available, they're very hard to come by, can damage the liver. So you want testosterone in an oil or a gel. And DHEA can also be successfully delivered orally, but we combine it with the testosterone. So we see no reason in most cases for oral DHEA. So best case, a woman receives 3 bottles of topical oils. Why 3? Because we like the bias administered twice daily. That's the safest, most precise scientifically. We like the progesterone at night because it helps with sleep. And we like the testosterone and DHEA in the morning. So it breaks down to 3 different bottles.
Nice. That is fantastic. I absolutely love that. And it sounds simple enough. Are people putting on their wrists? Are they putting it on the bottom of their feet? Does it matter where they're putting them? Just anywhere on the skin?
Well, it can be absorbed from anywhere. The skin is very absorbent, but some parts of the skin are more absorbent than others. So we recommend that the women put their estrogen, on their soft forearm.
Yeah.
And then rub it, put a couple of drops on there or a syringe and rub it together. We like progesterone in the lateral thighs or the inner thighs. We like testosterone in the lower abdomen, right or left, as if it was right over the ovary if they were lying down. It can be rotated to other sites. Bottom of the feet, you're the first one in 30 years who have picked up on that, because we do recommend occasionally, even though the absorption is not going to be great, estrogen is so good for the skin that we recommend that a woman every so often apply a little bias to the bottom of her, to the soles of her feet, just to improve the skin there.
That's another great benefit. It is certainly topically. I like that a lot. What's the longest you've had a patient on one of these protocols? Like how many years?
22 years.
That's great.
I moved, so I sort of began to practice again in Florida in 2000. I would make a guess that many of the women that we started in the early 90s are still on these. There's no reason to stop. We want to. No one will separate me from my testosterone until the day I leave Earth.
Yeah.
Or I can't get the cap off. And we recommend the same for the woman, because it's a myth that women should only take it for a short period of time. No, that was before people understood what risk really is. No, you take it for your whole life.
Does the dosage stay the same of a woman who's, let's just say, 55, 60, and then a woman who's taking it at 75? Do the hormone doses go down in any sense? Like the area under the curve is lower? Or would it be a good idea if you start early enough to just maintain like high hormone levels as still works for people throughout the whole course of life?
Excellent question. We monitor women that we're treating once a year with 24-hour urine hormone testing. And the early stages, the perimenopause, sometimes they don't need quite as much because their ovaries are putting out a certain amount.
Mm-hmm.
But once they go into menopause, they'll tend to use a little more.
Mm-hmm.
And, interestingly enough, most women stay steady for their whole life. Why not? What do we want? We want enough minimal to protect bones and vagina.
Yep.
And it takes a certain amount.
Yeah.
And so to maintain the brain, it could take even more.
Yeah.
Does not necessarily. So to maintain arterial protection. So we don't see these huge declines in need, especially when you take a look. And I always point to women on our medical board who are in their 70s and on hormones to take a look at how good they look.
Yeah, that's to say no more. I mean, that's something that's always very striking when you see a woman in her 70s who has great skin, great health, great vitality, and everyone wants to know what's she doing. There's a secret there somewhere.
That's right.
That's cool.
One of my dearest medical friends and colleagues, Devaki Berkson, she lectures to large audiences on hormones. And the very first thing that people do when they walk up to her is, "What are you doing?"
Mm-hmm.
Because she looks so great and is so active in every way you can imagine.
Yeah,
in her mid 70s.
That's beautiful. And I guess that's the promise of getting the hormones in check. And I also want to speak to the ladies right now who are not doing this, but are still trying quite hard with their exercise and nutrition and maybe feel like you're kind of running up against a wall. Is it fair to say that doing all these things under the presence of hormones, you see it in your patients that their results just go through the roof? I mean, now they feel like they're doing the right things, but they have the hormonal engine to back things up and make those lifestyle changes much more effective.
Well, glad you mentioned lifestyle changes. They're imperative. We don't get to live the lives we want unless we're doing the nutritional and exercise work that is so fundamental to maintaining health. Yet women are not able to sustain it on that alone, nor are men.
Mm-hmm.
And the replenishing of the hormones is probably the most potent thing that you can do in concert with nutrition, detoxification, exercise. But you need them. And I was taught this in 1968 by a gerontologist. He said, "You medical students, thousands of diagnoses. Let me tell you what's really happening to old people. They're losing their muscles and their bones, and they can't stand with stability, and they fall and fracture their hips and they die. You want to do something for older people? Help them with their muscles and bones."
Yeah.
And it's not possible in almost every instance to not lose muscle unless you are replenishing testosterone, men and women.
That's great. And plus exercise is raising these things as well. I mean, I can think of strength training plus the combination of these hormones would probably be one of the best things you can do after 50 for your muscles and your bones.
Ideal combination.
Mechanical stimulation and hormones stimulation. All right. So do you work, I'm assuming you work with patients like all over the country, virtual consults. I have a few more questions for you, but at this point I do want to ask you, because I'm certainly interested, and I'm sure someone else listening is interested, how they can get in contact with you and your team, how you work. You mentioned your book, which obviously might be a good place for people to start to learn more, but how do you work with people? And could someone come from this podcast and, go right to a consult or some sort with you and your team?
Well, the main thing that I do is I train and mentor physicians and nurse practitioners and physicians assistants to do this work.
Yep.
And because we've trained so many, almost in every state, there are people that we've trained.
Nice.
And it's growing every day. So the best thing people could do is go to bright.live, BRITE.live. There's a way to link with and see if we have someone in your state.
Yep.
Or email directly to Karina, Karina, at bright, BRITE.live.
Nice.
And we'll refer you to someone that is eagerly embracing the method that we choose, which I highly recommend.
Yeah, that's great. Now, a couple questions in closing here. One is, I want you to speak a little bit about not just the generation of women right now in menopause that you're helping age gracefully and the physicians you're training, but let's look at the current young generation. I mean, I think that we have a population of young kids that are getting on oral contraceptives earlier, exposed to more toxic environments, not eating great food, dysregulated with circadian rhythms. Like, what's some of your advice, although it's not exactly in your primary wheelhouse, for parents raising young kids, to help their hormones be right, or even just any commentary on where you think the trajectory of younger generations is going?
Excellent question, because it's a challenged generation. And I first met up with this in 1971 when I was through with my internship and the rigors of medical school and internship. I was exhausted, and I happened to get a job working for Planned Parenthood. And at first I thought, this is the greatest thing that's ever happened to me. I get to relax. I'm basically dealing with young women and giving them birth control pills, young, healthy women. And the more I did it, I started getting uneasy. And by 3 months, I resigned, because I thought giving a young woman a substance so powerful as to stop their ovulation.
Yeah.
What is this doing to them hormonally? Well, 55 years later, I've gone, there's so much information of how birth control pills, it's a complex topic. When you deal with some populations, that being able to choose about pregnancy or not is such a big deal.
Yeah.
That you would choose the birth control pill. So you never say never in medicine, but for the health concerned who can know how to be responsible for contraception, this is not what I would recommend. It's too many possible complications to young women to take the birth control pill. And I grew up in the era of condoms and diaphragms. I love them. I embrace them. The IUD has gotten so refined. A simple copper wound IUD can do so good for someone in a committed relationship. For someone who's not, you want to add a condom to this to protect against STDs.
Mm-hmm.
There are far better, safer, more healthy ways for contraception. Not an easy topic. So you never say never about the birth control pill, but it's the least favorite of mine for health reasons.
Yeah, probably because you have a deepest understanding of how potent these hormones are than most people. So,
geez, stop fertilization. Whoa.
Yeah.
And it messes with the woman's cycle, and it knocks out her progesterone. And there's other things that knock out the progesterone. Almost what's new to this planet are these women who are experiencing early declines of the hormone progesterone. And they're developing, because progesterone is a great calmer, they're developing this anxiety out of the blue. We all face stresses of life, but when a young woman is lost in anxiety, you want to think first, these days, that she's no longer producing a robust amount of progesterone. And if she's not regularly menstruating like clockwork, I mean, every 28 or 27 or 29 days, she's probably not ovulating. Thus, she's producing almost zilch progesterone.
Yeah.
So when a young woman has mood disorders, PMS, pain, very painful periods, one of the first things we want to do is get an assessment of what's going on there. And one of the most likely things we're going to find and can assist them so much with is just a bioidentical progesterone.
Mm-hmm.
Because that's usually what's going on there. Such a simple thing. It's even available over the counter in dosages that young women can benefit from. So, that's the worst thing that's happened.
That would be someone could just take that in the latter part of their cycle and just create a more bioidentical rhythm, or would they take it pretty constantly?
Well, that was my first thought. And when I started out prescribing progesterone, since progesterone is so robust, during the second half of the cycle, if a woman ovulates, why not copy nature? That's what I did. But I learned over time that no, by the time there's not enough progesterone, you probably want to administer every single day. How did I learn this? I taught my patients who were progesterone deficient, look, let's copy nature. Just take it during the second half of your cycle. Well, the women came back to me and said, boy, during that second half of that cycle, I feel so great. Is there any possibility I could take it during the first half of my cycle? And I thought, well, why not? It's so beneficial. And uniformly to a woman, they would say to me, well, I already am doing it. It works great. I'm taking it every day. I just wanted to get your blessing.
Nice.
So what it brings up, Anthony. Can I call you Anthony?
Yeah, please.
Yeah, please call me David.
Okay.
What it brings up is that individualization is so critical in this work. We can have our theories of what to do in general, and they're great, they're applicable. But when it comes down to good treatment, you need to individualize. So, yes, a young woman could try progesterone in the second half of the cycle, but she may need it during the first half of the cycle as well, even when she's menstruating. So you figure it out. Each woman figures it out on her own in conjunction with her prescriber. And that's one of the things that we go into such depth with in the book, so that because it's a partnership between prescriber and the woman. These hormones are going into the woman's bodies, and they're so individualized.
For sure.
So you do that partnership, that synergy, and ultimately you wind up with an optimal program.
Well, that's great. And I think this is my perfect segue into my final question. And it's driven by a lot of my personal curiosity, but like, what's the next several years look like for you? I mean, your mind is so sharp. You're probably at the peak of your medical wisdom. You're helping create practitioners that can administer this type of proper bioidentical practice. Like, what do you see as your future of your next several productive years, or maybe even decades for that matter? Like, what's next for David?
And if we want, we can circle back to that wonderful topic you suggested in the beginning also. I'd be happy to do that. Well, I'm 81.
Wow.
I'm at the absolute
I had no idea. I thought, maybe I was going to throw you in the early 70s. So good job. I think you're doing good medicine.
And I'll tell you, men, this is part of it. And I'm at the absolute pinnacle, the most creative, enjoyable part of my whole career. And I've always loved medicine. I love it. And I loved it in medical school, and I love it at the absolute maximum now. I have partners and that are just wonderful. Our mission is to get millions and millions of women back on hormones, men as well. We treat men as well, because we feel like this world, this planet desperately needs more feminine energy in the halls of decision, in the home and business and politics, everywhere, that major decisions. So that's how we feel like we can contribute to the healing of the world. And we really mean it. My partners really mean it. And we've got a wonderful team. Oh my God. So it's big fun. It's like,
I can tell.
I can't imagine stopping. I don't see a reason to stop. We finally made it to the big fun. So that's, I'll be doing it. My father practiced until he passed away at 92.
Wow.
So
I think my estimation and intuition says you're on track to certainly surpass him in terms of productive years. And that's saying something, because 92 as a practicing doctor is something.
Yeah.
Cool. Well, I got to say, I'm really inspired by you. I thought this was a beautiful conversation. I want to make sure, again, that people know that your book, to go get that, because that seems like a really great resource to continue to connect with you as well. Can you mention your book? And then again, there's a couple websites, the Bright website as well as any other, so people have it on the tip of their minds to go search that now.
Well, it's bright.live, BRITE.live. The book is Happy Healthy Hormones, which they can download off your website, can't they, Anthony?
Yes. We'll be able to have it in the show notes. Yeah. Happy Healthy Hormones.
Yeah. And it's a free PDF version of the whole book. And then for professionals, the best way to reach out to our training program is through iobim.org, IOBIM.org, Institute of Bioidentical Medicine, IOBIM.org. That's for professionals.
Wonderful. David, this was a pleasure. I know you're a busy man, so we're going to get you back to your robust practice.
Do you want to mention what you and I talked about just before?
About Suzanne Summers?
Yes.
Okay. Well, we'll bring it up. I think that'd be maybe a nice closer. And like, for those most people are probably familiar, Suzanne Summers, actress. I think she invented like the thigh blaster. She had a huge impact on many people getting on bioidentical hormones from her 20 plus books that she wrote over the years on the topic. And at the time of recording this, she sadly passed away pretty recently after, I believe, a multi-decade battle with breast cancer. And so I'm sure this could be an opportunity where many alarm bells could be rung again, that, look at this as an example of, estrogen and, how hormones and bioidentical might have played a role in her cancer. So I'd love for you to speak into that in closing.
Well, first about the cancer. Cancer is a very serious illness. And like all serious illnesses, it's got a multitude of causes that take place over the course of her life. She didn't have a perfectly stress-free life by any means.
Very busy.
And hormones don't cause cancer, but a lot of things do. And, we could go down the list. And she, when she acquired it, although she had the best treatment and she lived for a long time with a great deal of vigor and libido, for example, that illness is a very strong illness and not everyone gets to beat it.
Mm-hmm.
But you can dive into Dr. Blooming's book to see that the science actually is that women who are treated with hormones do better in the long run than women who are not treated. Mm-hmm. Well, she was not one of those who continued to do better. And the other part about Suzanne Summers is I was deeply touched by her. She affected our holistic world amazingly. I once heard her speak in front of a couple thousand doctors at a major conference of A4M. She was brilliant, and she was a health advocate of the highest order. I thought, well, this is an actress, they wanted her up there for entertainment. No, she was a world-class speaker.
Yeah.
And then I testified in front of the National Academy of Science committee that they had formed on the safety and efficacy of bioidentical hormones. And 3 weeks before, I was able to contact Suzanne and ask for her support. And if anyone ever views the video, there's a stack of papers there, which is about 300 testimonials. She generated them like that. She said, sure. And she just immediately, that day, she posted on some of her social media, please, we want testimonials. Dr. Rosensweet's going to Washington. And there they were with just 300 of them that she produced. So I had a and you know what? I've been to Washington recently. On my list in the next 2 weeks was to recontact her to see if we could garner another level of support from her. So, and it was very sad. And she was a dear friend and of a dear pioneer, Dr. Jonathan Wright, who wrote books with her, who was one of her physicians for many years. So,
well, I'll say this. What feels appropriate to say is, one, it sounds like you did lose a friend, a professional advocate, and I'm sorry for your loss. And two, that her work and her dreams do live forward still through your continued energy that you're putting out there. This is the world that she wanted to live in, a world with lots of vital people who have great life energy through this practice. So, I think the physical bodies die, but what we stand for lives on. And I know you're propagating that. So good job. And thanks again. Wonderful conversation. I appreciate you so much. And I'm excited to get this out to our community.
It was a co-creation, so it's special for me as well, Anthony.
Thanks, David.